It's my great pleasure to introduce Dr. Pro. Dr. Pro will be starting with our lymphoma overview and update on COVID-19. Dr. Pro is the clinical director of the lymphoma program and professor of medicine at New York Presbyterian in Columbia, and she is also one of the esteemed members of our scientific advisory board. Thank you, Dr. Pro.
Good morning. Thank you so much for the kind introduction. It's really a pleasure to be here today with all of you. So I hope you enjoy the day. So in the next 15 minutes, I will be brief. We will go over just general basic information about lymphoma. We will give you more specific information at the time of the breakout sessions. But so I just want to go over, a few things again. What is lymphoma? Who gets it? We will go over diagnosis, staging, and just general information about treatments that are available for this disease. So what is lymphoma? Lymphoma is really a very broad term that we use to define a cancer that begins in cells of the lymphatic system. So the lymphatic system produces white blood cells, and particularly two main types, B cell and T cell. The lymphatic system is very important because it's a defense against infections and diseases. So we do need these cells to fight all the time because we are exposed to microorganisms and the possibility of having illnesses all the time. And this is, again, the first line of defense that we have in our body. Usually, lymphoma starts when these cells that are supposed to fight grow without any control and produce more cells. And the lymphoma typically start in lymph nodes. And you see on the right how lymph nodes are everywhere in our body. But lymphoma can also involve the spleen, the bone marrow, and other organs in our body. There are two major types of lymphoma that you need to know about: Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is extremely rare and is characterized by these cells that you can see here that are large cells and are called Reed-Sternberg cells. And typically this disease involves lymph nodes that are swollen in the neck, in the chest, and under the arm, and typically progresses to involve more lymph nodes in the body, like in the abdomen, and can eventually, in advanced stage, involve also other organs like liver, spleen, and bone marrow. It's very important to distinguish these two main types because treatments, as you can hear later at the breakout session, is completely different. Non-Hodgkin lymphoma is more common than Hodgkin lymphoma, and it can be divided in two major groups: T-cell non-Hodgkin lymphoma, which is extremely rare, and B-cell non-Hodgkin lymphoma, which is more common. How many cases of non-Hodgkin lymphoma are diagnosed every year? You can see here that actually non-Hodgkin lymphoma is rare. It accounts for only 4% of all cancer diagnosed every year. So there is an estimated number of cases in 2023 of 80,550. However, the risk of developing this type of lymphoma increases throughout life, with more than half of the patients having lymphoma, being diagnosed with lymphoma, having 65 years or older. And you can see from the graphs on your right that, again, the risk of lymphoma increases with age. How about Hodgkin lymphoma? I said Hodgkin lymphoma is very rare, so there are about close to 9,000 cases of Hodgkin lymphoma diagnosed every year, so represent about 10% of all cases of lymphoma diagnosed in the United States. It's more common in younger patients, around 20s, but the risk again rises in late adulthood, after the age of 55. Overall, the median age of people when they are diagnosed with Hodgkin lymphoma is 39. So you can see that if you look at the incidence, the risk of developing lymphoma, there are two peaks, one for young patient and one for older patient, older than 55. Who gets lymphoma? What are the risk factors? And the list is very long, but I just wanted to summarize the most important risk factors for developing lymphoma. So having a weaker immune system, it definitely increases the risk of patient developing lymphoma. So any type of immunosuppression, like patients who have autoimmune diseases or patients who underwent organ transplant, have an increased risk of developing lymphoma. There are also some infections that are associated with an increased risk of developing lymphoma, and these include both viral infection and bacterial infection. You can see here the list of viruses that can be associated with lymphoma, the most common being the HIV and the Epstein-Barr virus. In terms of bacterial infection, typically these bacterial infections are associated with slow-growing lymphoma, like the mold lymphoma. And the most common is Helicobacter pylori, which can cause, as you probably know, a stomach lymphoma called mold gastric lymphoma. How is lymphoma diagnosed? Most of the time, patients will present to their primary care physician with swollen lymph node. And typically, these lymph nodes are swollen but are not painful. So they can be in the neck area, they can be under the arms, or they can be in the groin areas. And typically, the doctor will ask a medical history to know if there are any risk factors for developing lymphoma, and they will usually perform a physical exam. Again, the physical exam will be checking for swollen lymph nodes, checking for liver enlargement or spleen enlargement, or sometimes even a skin rash. Patient can also present with an itchy rash. So if we suspect lymphoma, then we start just with routine blood work. And in the blood work, what is important is to obtain a complete blood count, to check for the number of lymphocytes, to check to see if there is any anemia or if the platelets are decreased. We also check for some specific marker, like sedimentation rate. This marker called ESR, it's important to detect inflammation in the body, and is typically elevated in patients with Hodgkin lymphoma. We also look for another marker that is also important in lymphoma, which is called lactate dehydrogenase. And this marker actually detects a large amount of cells that grow and die, so cell turnover. We also look for liver and function tests, making sure that there are no abnormalities in this organ. And sometimes we do some specific testing, like looking for abnormal protein that can be elevated in some particular subtypes of lymphoma. We also sometimes do some tests to detect if there are peripheral blood involved. There is peripheral blood involvement with lymphoma, so there are cells that are circulating in the bloodstream, and this specific test is called peripheral blood flow cytometry. Eventually, we do imaging studies, and in the past, we used to do ultrasound or CT scan to detect the presence, again, of lymph nodes that are enlarged throughout the body, or any organ that can be enlarged and affected by lymphoma. But these days, we typically do a PET CT scan. MRI and bone marrow biopsy are done only when indicated. Eventually, the diagnosis of lymphoma cannot be made without a biopsy. So if the lymph nodes are swollen, we typically recommend an excisional lymph node biopsy. A fine needle aspiration is never enough to make the diagnosis of lymphoma because usually the amount of tissue that we get from a fine needle aspiration is very small, so we are not able to do all the testing that is needed to make this very difficult diagnosis. How do we decide what is the staging? We use something called Ann Arbor staging, and you can see the table here. So stage 1 is when there is only one or a couple of lymph nodes that are swollen in the same area of the body. Stage 2, when you have both sides of the body involved by, again, swollen lymph nodes. Stage 3, when you have lymph nodes throughout the body. And stage 4, when there is also organ involvement, like liver or other organs like kidney or lung or stomach. So we also say patients have a certain stage, like stage 1 or stage 4, A or B. And the reason why we say that is because B means that patients have what we call constitutional symptoms. And constitutional symptoms are fever, drenching night sweats, and weight loss. And A, when patients do not have these constitutional symptoms. Usually the presence of constitutional symptoms is associated with more advanced disease. So we said Hodgkin lymphoma is very rare, and non-Hodgkin lymphoma is more common. There are many different types of non-Hodgkin lymphoma, over 90 types. But in order for you to understand how we really assess lymphoma in terms of how we decide what the clinical course of the disease is going to be and how to approach the treatment of these diseases, we usually divide the lymphoma in 3 main categories. Those who are slow-growing, those which are intermediate, so aggressive, and those which are highly aggressive. So the most common indolent ones are follicular lymphoma and marginal zone lymphoma. Then we have mantle cell lymphoma that sometimes, rarely, can be indolent. In most cases, it's usually aggressive. The most common aggressive lymphoma is diffuse large B-cell lymphoma, and there is a specific subtype of diffuse large B-cell lymphoma which is more aggressive than the standard subtypes and is called double-hit lymphoma. And then we have the very aggressive, the so-called high-grade lymphoma and Burkitt lymphoma. So you can see on the right that under the microscope, these cells look completely different. In follicular lymphoma, you have cells that look very small, and when you do some proliferation markers to look at how these cells are growing, usually those markers show that very few cells are actually growing at any given time. The diffuse large B-cell lymphoma is in the middle there, and you can see that cells are actually larger, and typically they grow, but not as rapidly as in Burkitt lymphoma. And the last one there at the bottom is Burkitt lymphoma, and the brown staining is actually the proliferation marker called Ki67, and you can see that most of these patients, 100% of these cells are growing, and that's why this brown staining is everywhere in this slide. So this is very important because, again, it does guide therapy. I also want to mention that we have to differentiate B-cell lymphoma from T-cell lymphomas. T-cell lymphoma are usually aggressive and are extremely rare. They account only for 10% of whole non-Hodgkin lymphoma diagnosed every year, so approximately 9,000 cases per year. How about chronic lymphocytic lymphoma, leukemia and small lymphocytic lymphoma? These are slow-growing types of blood cancer. In CLL, the abnormal B cells build up in your blood and bone marrow. In small lymphocytic lymphoma, the same type of cells build up in the lymph nodes. So they are the same disease and they're treated the same. Most people with CLL and small lymphocytic lymphoma do not have any symptoms at the time of diagnosis, so we typically just watch patients for a long period of time until they develop symptoms or there are indications for treatment. So I mentioned before, we divide lymphomas in slow-growing, intermediate, and aggressive, and the treatment really changes according to what type of lymphoma we are facing. So in indolent lymphoma, as I mentioned, typically we watch patient until treatment is indicated. And what are the indications of treatment? For treatment, the presence of these symptoms, so fever, drenching night sweats, and weight loss, the presence of very large tumor masses, so lymph nodes are enlarged and they are causing problem with other organs. So typically we define that as more than 7 or more than 10 centimeters in size, the presence of pain, or the presence of anemia, so low hemoglobin or low platelets. And typically in slow-growing lymphoma, we tend to avoid chemotherapy if possible, and this is considered more of a chronic disease. So it's slow-growing, chronic, so treatment only if needed. It's incurable, but highly treatable, and you will see in the breakout session that we now have many, many options, including oral treatments for these diseases. In aggressive lymphoma, the treatment approach is different. I told you these cells grow very quickly, so usually the treatment needs to be started right away. We can't wait, and the treatment typically includes chemotherapy plus immunotherapy, and the goal for these diseases is a cure. So historically, we have used 2 types of treatments in lymphoma, chemotherapy and or radiation therapy. So, but chemotherapy is using cytotoxic drugs that destroy cancer cells, but they cannot really distinguish between cancer cells and healthy cells. That's why one of the problems when we use chemotherapy is that patients can develop low counts, just because the chemotherapy also kills healthy bone marrow cells. And the bone marrow produces healthy cells too. And radiation therapy, it's another modality that we have used in the past, and some specific types of lymphoma are very sensitive to radiation therapy. So we are still using radiation therapy. And radiation therapy uses energy beams that penetrate the skin and kill cancer cells in the body. Now, it's very important that you see someone who is expert in delivering this radiation therapy, because the doses and location of the radiation is very carefully planned to target only the tumor cells while sparing healthy cells around the tumor. But what is happening lately? I think we are shifting completely the treatment of lymphoma. There's been many, many breakthroughs in the treatment of lymphoma. So we are doing more and more what we call personalized targeted therapy. So we are looking not only at lymphoma as a general group, but the specific types of lymphoma. And even within the same category, we now are able to distinguish different subtypes for which some therapies can be more targeted, depending on the biology and the unique alteration abnormalities that we can find at the genetic levels in these diseases. So we are trying to shift away from chemotherapy and one size fits all, and you will learn more from Dr. Munoz and Dr. Dunleavy that I think the major breakthrough in lymphoma has been the use of immunotherapy. And we started with simple naked, what we call naked antibody, like Rituxan and obinutuzumab, and now we have not only this naked antibody, but we have antibodies that are linked to cytotoxic agents, so chemo drugs, but they are targeting a specific protein, so they deliver these cytotoxic drug, this chemo drug, only to the cells that are cancer cells. So they're called antibody drug conjugates. And now we also have the bispecific antibody that let our own immune system fight the cancer cells. So incredible breakthrough in the treatment of lymphoma. So what are the future directions? I think we need to learn how to use the most effective therapy for specific subtypes of lymphoma and also look at the toxicity of the different type of treatments that we have available. For patients who have relapse or disease that is refractory to a certain treatment, we need to know how to best sequence the many options that we have now available. We need to focus more, because I think in the past this was lacking. This is a significant knowledge gap. We need to focus more on nutrition and supportive care for our patient, and also, very importantly, during these times, how to deliver safely and recommend safely treatment in the COVID-19 era. So I think these are just some information about COVID-19. We do know that the individuals who are immunocompromised and are undergoing treatment for hematologic malignancy are at an increased risk of developing more severe infection with COVID-19. And also I want to emphasize that it's not only the infection, they shed the virus for longer period of time. So very important that you recognize that. And they can also be symptomatic for longer period. And the treatment with antibodies like Rituxan or specific chemotherapy like bendamustine can actually increase the risk of this longer shedding of the virus. I think you also have to recognize that it's not only the active treatment with chemotherapy, but also patients who undergo specific treatment like CAR T, so immunotherapy with CAR T, or stem cell transplantation are at increased risk. I think the most effective way to prevent infection remains vaccine. So please follow the CDC guidelines about the boosters that are needed when the virus is changing. I think it's important also to recognize that it's not only the patient that needs to get the vaccination, but also caregivers and family members to decrease, again, the risk of exposure. Very, very important. You need to discuss with your doctor the best timing to receive the vaccine or the booster, because sometimes if you receive steroids or antibody therapy, you need to try to time the vaccine a little bit away from the time of the steroids or this antibody therapy. And I think it's also very important that you recognize that patients who are immunocompromised and have been on treatment for lymphoma can have a significantly decreased response to the vaccine, but studies have shown that if you receive a second dose of boosters, actually the amount of response that you have to the vaccine increases over time. So very important that you recognize that. And I think this is the end of my presentation. Thank you very much for your attention. We will be able to take questions at the end of the 3 presentations, and you will now learn more about novel treatment in this disease and also the clinical trials that are currently available. Thank you so much.